The next question I have is, are any of the new techniques more useful to determine the number of involved lymph nodes or size of the cancer for predicting the need for chemotherapy? Okay, so this is the question of, who gets chemotherapy and who does not need chemotherapy after having a colon resection. So let me start with the easy part. For stage 3 colon cancer, we generally recommend 6 months of chemotherapy. And stage 3 would involve the cancer having spread to the lymph nodes, either if it's through the wall or not through the wall. But any lymph node involvement puts you into stage 3, and then we would normally recommend 6 months of chemotherapy. If it's stage 2, then there is a division of medical opinion about whether chemotherapy should be done or not. And that is really a little bit, the reason that there is a controversy in that is because there is no single definitive trial that shows the benefit of modern chemotherapy for stage 2 colon cancer. The reason that's true is because, number one, most people are cured with stage 2 with surgery alone. So to show that chemotherapy would be helpful, you need to treat a lot of patients, like several thousand in a clinical trial. And to date, there are no clinical trials that have been reported with that many patients. There's one that may come out in another couple of years. It's just finishing. But that's really the first one that's big enough to show an effect. And number two, the benefit of chemotherapy as the cure rate gets higher is maybe the same relatively, but the absolute benefit is smaller. So for people who have an 80 or 90% chance of cure with surgery alone, the benefit of chemotherapy may be only 3 to 5%, so therefore people wonder if they can do a better job of predicting who needs chemotherapy. So that brings us to the question that that was posed: what are some of the better things? So, as I described for the staging, that is really based on looking at the tumor under the microscope, and that's pretty much a 19th century technology. The microscope was invented in the 1800s. I think we got better at doing kinds of tissue processing and staining, but by the early 20th century, this was all set. And the question is, what can we do today, knowing what we know about molecular biology, to help decide who's going to be cured and who's not going to be cured? So there are many people who are looking at gene profiles, where we would actually take the DNA out of the tumor after it's removed from your body and analyze the gene expression profile of these tumors and to determine which are the bad actors and which are the better actors. And the better actors would have a very high chance of being cured, more like stage 1, and therefore they wouldn't need treatment. And the bad actors are more like stage 3, and they should get treated. So that is really the goal of certain tests. One test that we are using today for that is a test called Oncotype colon, and that's similar to a breast cancer test. There's another one that isn't approved in the U.S. yet, but is still under development, called Coloprint. And then, for example, in this large study that I mentioned from the sponsored by the National Cancer Institute, they're looking at 2 separate profiles, one a loss of a certain chromosome and another microsatellite status. So using those 2 things, I think we're trying to figure out which stage 2 patients could benefit more from chemotherapy and which do not need that.